Gracias. Lo siento, mi español es muy malo. But I want to tell you today that at the end of the talk, 30 minutes, I want to convince you that AKI and CKD are not only an interrelated syndrome, but they're the same thing. I think we've been teaching our medical students for 50 years the wrong thing. Thursday they get AKI, Friday they get CKD. This is not correct. So I will talk about the clinical epidemiology. I will try to talk a little bit about what's acute and what's chronic and how they're integrated. I want to talk about treatment. I will talk about some basic science issues. I'm not going to have time to talk about biomarkers, but I will want to talk about research implications. So, very simply, AKI is common, it's deadly, it costs medical systems a lot of money, and yesterday Dr. Levy spoke for hours about public health issues. We have public health issues in AKI because AKI is associated with cardiovascular disease, it's associated with CKD, it is associated with end-stage renal disease. This slide simply says that the number of hospitalizations of AKI is exploding in the United States. Now, partially this may be administrative and for billing, but the number is clear. Exactly what the number is not clear. And you see this as the percent of hospitalizations as well. There is a clear increase now to 4% of hospitalizations, and these data are from 2006, so it's probably 5 or 6%. Very common. And this is a paper we published in 2006, and you can see that the patients who are most at risk are the aged, and specifically in the United States, African American patients at risk. So I want to leave you with this logo. AKI is CKD. And hopefully you will see this published in a beautiful journal. I hope it's as beautiful as Dr. Serda's slide. But there is a very interesting conundrum. If you look at the end-stage renal disease program in the United States, the prevalence of CKD at earlier stages does not explain the incidence of end-stage renal disease. It explains about 60–70%. Where are these other patients coming from? But we do know that the incidence of acute kidney injury is increased in CKD. And Dr. Levy even mentioned this in his talk yesterday. And the data are by Chi-Su and colleagues in San Francisco, our data from Jason in 2006, and our data from Jason in 2009. And since I made this slide, there have been several others. There's a nice review of this issue in Kidney International by Coca in 2011. So why should CKD be a reason for the development of AKI? And I think when we started these studies, the statistician said, what is the rationale? You know, statisticians are very, very forceful. And we had to try to explain that. And I think there are 3 good reasons for this. One is, it is easier to see a small change in the GFR, which is the definition of AKI, if you have advanced renal disease, if you have high-stage CKD. And I will just show you the curve of creatinine versus creatinine excretion in the next slide. Also, the patients with CKD have a chronic illness, and they are more exposed to risk factors. They can get more nephrotoxic antibiotics, they may have cancers, they may have more run-ins with the medical system. And fundamentally, I think the issue is patients with CKD, as we all know from the first year of medical school, have problems with autoregulation and tubular function. So it's natural that if they become sick, they should have an episode of AKI because the autoregulation is not good. And here on this slide, you can see that at the low levels of creatinine clearance, a small change in the GFR is associated with a big, very clinically applicable and apparent change in the creatinine. And we know this from the first year of medical school. But that is what AKI is in a CKD patient. And this is the way that I think about how AKI may affect the course of CKD. In CKD, in a very stable patient, you often, not always, have a loss progressively over time of renal function. We know this for 25 years. We're familiar with this from Dr. Brenner. But if you have periods of AKI interwoven in the patient's course, you may have a very variable course, and I've tried to illustrate this by valleys and mountains, but some patients may have a very poor course resulting in this blue line that approaches the x-axis. And this slide was made for me by Dr. Chawla, my collaborator, and if you look at the number of people in the world who have AKI, it's about 2 million a year. And the survivors are about 1.7, because AKI is not acute renal failure. It's not dialysis. It's not 50% mortality or 80% mortality that we talk about. So those AKI patients, about 10% will go on to have end-stage renal disease. And I will show you some data about this. And it's not just my data, because several other investigators have shown the same thing. And we knew this clinically. A certain number of patients who had acute renal failure were going to end up on lifelong dialysis. We told them when we were dialyzing them, we don't know if you're going to be on dialysis forever. We think you'll get better. Finally, who are those survivors who don't go on to end-stage renal disease but don't recover their function completely? Those are patients with CKD stage 4. And if you look across the globe, across the world, it may be 1.5 million people a year. This is data from the United States, and it simply shows that the number of AKI admissions in patients who have CKD is substantial, about now 15%, and is growing each year as we are better in diagnosis, and maybe the CKD classification system is helping us. And you see that the probability of developing end-stage renal disease following AKI is enormously magnified when the patients have CKD in the light blue lines. And you see that the percent of patients who had an AK hospitalization that go on to end-stage renal disease is also substantial. If you are hospitalized and the doctor makes a diagnosis and bills Medicare for AKI, that patient may have a 1/3 chance of going on to end-stage renal disease, dialysis or transplantation, in 2 years. So the clinical question is, does AKI predispose to CKD? I think the answer is yes. I'll show you some data. And this is Dr. Serda and Dr. Egger's beautiful slide, which shows the many kinds of consequences that you may have after an initial insult. And we're going to focus on the bottom green lines and red line. This is a paper that we published in JASN about 3 years ago. We used Medicare claims. This is observational data and administrative data, so it may have many problems. And we used the diagnosis codes in the Medicare system. You can see there are 100. So you have to take this data cum granum salis, with a grain of salt. And there are very few AKI diagnoses as well. I don't have a pointer, I'm sorry, but the business end is at the very bottom. If you have AKI, the mortality is about 2-fold. We know this. If you have the combination of AKI and CKD, the mortality is almost doubled, 3-fold. That's all I want you to know from this complicated slide. And now, this slide, you can't see at the top, it says, what is the probability, what are the hazard ratios of developing end-stage renal disease? And if you have both AKI and CKD in a billing document sent to Medicare, the relative risk is 40 times. You never see this in clinical medicine. It's like one of Dr. Levy's slides. Right? It is higher, 5 times higher than the rate of going on to end-stage renal disease in patients who have CKD, stages 3, 4, 5. So AKI is a tremendous magnifier. And these are the data that are illustrated as a Kaplan-Meier graph, and you can see that there is complete separation of the lines between AKI and no AKI and between the different groups. If you have the combination of AKI and CKD, there is a very, very high probability of developing end-stage renal disease. And we know this. We know this clinically, but we didn't have the data before to show it. I told you I am not a great believer in the AKI God. AKI is not acute renal failure. And I like the old acute renal failure with prerenal azotemia, intrinsic renal disease, and obstruction. And that's the way I think we should teach our medical students. However, the two major causes of acute renal failure and AKI are prerenal azotemia and ATN. And we know that only some people who develop ATN develop changes in laboratory parameters, changes in clinical status, or need for dialysis. And we had almost no natural history data about the very common nephrologic diagnosis, ATN, acute tubular necrosis. So we asked the question, what is the natural history? And the study was published in Kidney International 3 years ago. And this is the business end of the study. If you look at the patient's change in creatinine, AKI, and you divide it into quartiles, the highest quartile develops over time, this is between 3 and 5 years, a substantial increase in the average creatinine. Less severe kidney disease approaches normal, less severe AKI. But for those patients who have a doubling of creatinine, the long-term course is not good. Same thing for the peak creatinine or severity of kidney injury. And these are Kaplan-Meier estimates. ATN and acute renal failure have actually better survival than patients with CKD. And the numbers are on this graph, I won't go into it. But if you look at all these patients, and none of the patients without CKD had CKD beforehand. They were removed from the study. So when we are talking about acute renal failure in general or a specific diagnosis of ATN, a substantial number of patients, 20% of the patients with acute renal failure as a diagnosis, went to CKD stage 4 from CKD 0 over 5 years. And the number of patients with ATN had poorer survival and also had 20% of those patients developing CKD stage 4. This is remarkable as far as I'm concerned. And these are the data. I don't have time to show you that. These are not just my data. Several other people have shown very similar data from Canada in the United States End-Stage Renal Disease Program in a meta-analysis from Canada. So this phenomenon in observational studies, in administrative data, are quite clear. We don't have good prospective observational data. And this is a paper from Dr. Ishani. It shows clearly that the severity of AKI is associated with end-stage renal disease, much like our data. So, brief summary. Following a diagnosis of ATN or acute renal failure, 20% of the patients, the creatinine does not return to normal. they have about a 20% risk of entering CKD stage 4 in 18 months after diagnosis, even when there's no pre-existing renal disease. They are certainly more likely to enter CKD stage than the controls, and the controls that we used were patients with myocardial infarction and pneumonia, so they were sick, and you saw the death rates in those patients. The severity of AKI is associated with CKD progression. I don't have time to show you the data, but a low concentration of serum albumin is also a good predictor of progression to CKD. And I would like to break that vicious cycle of AKI and CKD and AKI to end-stage renal disease. We have to interrupt this. These data that I show you are not new. Dr. Merrill published outcomes of patients in the New England Journal in 1956, and you can go to the New England Journal archive and find it. 20% of the patients with normal renal function had low GFR in follow-up. Nobody remembers this. They thought the outcome was good. A similar study from England. Very small number of patients. They all had measured GFRs with inulin, not eGFR. Well, how does AKI go on to CKD? I showed you patients who had no initial CKD. And I think there are very interesting possible reasons. We don't know them for sure, but we have good ideas. What about genetics? I told you yesterday about ApoL1. We know that African Americans have a poorer prognosis. I think this is a very interesting idea. We know that if we look at some biopsies, certainly not all, and not the majority, of patients with ATN, you can see necrosis of the tubules, you can see apoptosis. Not everybody. But I think what results in chronic kidney disease is an imbalance between repair and maladaptive repair, fibrosis. And fibrosis is the enemy, exactly like Dr. Halloran was speaking about before. And I think it's an imbalance between inflammation and apoptosis, between heme oxygenase and hypoxia, in the regulation of TGF-beta. Small amount of TGF-beta is anti-inflammatory, a large amount creates fibrosis, and how the cell cycle is affected. And these are illustrated in several articles. We had an article in Kidney International in September. Dr. Venkatachalam has a beautiful article in the American Journal of Physiology in 2010. I'm going to show you a picture from an article by Wynn in Nature Medicine. Very beautiful, I think. And this is the article. He said in an editorial that if you have acute kidney injury, you have heterogeneous dysfunction of cells, but you have an active regulated cell cycle, small amount of TGF-beta is produced, a small amount of fibroblast response is produced, and generally this is wound healing. That's what you want in AKI. You want the wound to heal. If you have pre-existing CKD with malfunction already, or you have a tremendous amount of injury, you don't repair easily. The cell cycle goes into arrest, TGF-beta is poorly regulated, and you end up with a fibrotic response. Ooh. We conceptualize this in a slightly different and maybe more simple way, and this was the cover of Kidney International in September. If you have a normal kidney and you have acute tubular necrosis, that is marked by inflammation, more or less. You have the infiltration of immune cells, endothelial injury, the blood vessels are affected, there are cells and casts within the tubule. There are two possible outcomes. One is a very nice normal repair, and you have a patient with a creatinine of 1.0, and one is the development of CKD. And that can be marked by interstitial fibrosis, hypoxia, a poor blood supply, and cell cycle arrests and epigenetic changes. And these are the areas that we could change in the long-term outcome for acute renal failure. So one thing you can categorize, acute kidney injury, you have a small amount of injury, you have normal repair. Severe injury, cell cycle arrest, TGF-beta is elaborated, the genetic modification occurs, you develop myofibroblast activation, results in interstitial fibrosis. Interstitial fibrosis is CKD. So how do we treat ATN right now? We don't treat ATN, we dialyze the patients. And you see there is no difference if we intensively dialyze the patients or we dialyze them 3 times a week. We have to have better therapies. This was a wonderful study, but it was negative. So what could we do to improve ATN or AKI? We could try to prevent it. We are not having success with this. We could try to have early intervention. I think this is a tremendous area for research, but very expensive. We could try treatment post-injury, and we've used biomodifiers, but you know that we've used natriuretic peptides, insulin-like growth factors, others, and the results are all negative. Is it we do it too late? This is what the biomarker people claim. Or are these therapies ineffective for the factors that I outlined? We don't know. But again, we have to interrupt the cycle because the outcome is more cardiovascular disease, more disability, poor quality of life, death. So what might we do? These are the problems. I'm going to be very negative. We don't know to whom to give a drug. We don't know which drug could work. We don't know when to give the drug, early, late, in the clinic afterwards. We don't know how to give the drug. 1 time, 4 times, 11 times. The drugs we use don't work. We may need more than 1 drug, and when we use more than 1 drug, the toxic events may be incredible. Hyperkalemia, neutropenias, all kinds of problems. We need to do more clinical studies, and we have to have a better basic science set of data because the animal models are not representative of the human disease. So we have tremendous problems in this field. These are the lists of the basic science pathways that could be interrupted. And I don't have time to go into all of them, but there are many, many ideas, very little data, very little money. What is my institution, the National Institution of Diabetes, Digestive Diseases, and Kidney Disease doing? We have a natural history of acute kidney injury program. There are 4 clinical centers investigating AKI after cardiovascular surgery, after acute lung injury. One study is a community hospital where they're both using ward and ICU patients, and an ICU population. And then we have a data coordinating study. We have some ancillary studies. We have some challenges in this study because they are mostly recruiting patients who have very mild AKI, rifle stage 1, because the sick patients are too hard to recruit. So we're going to end up with a study 2/3 R, 1/3 I and F. We have problems. This study will look at long-term mortality and renal outcomes, long-term cardiovascular studies, and biomarker studies. It's about halfway finished. We expect the data to be in 2017 or 2018. We also had a workshop in December 2010. You can go to the website for this workshop and find the report. But the NIDDK would like to encourage interaction between industry and academics to make it more likely that industry will try a high-risk program because the NIH will participate, perhaps create a safe harbor. And I think novel clinical endpoints. This is the first time I heard Dr. Levy mention MAKE. We are interested in Marseille, major cardiac and renal endpoints. So more inclusive, comprehensive endpoints, more events. Whether it will work, no lo sé. Again, we must interrupt this pathway. But what are we doing now? What are we doing clinically? When I'm at George Washington University, you see a patient in the ICU, dialyzed for 3 weeks, the creatinine is 2, you say, hasta la vista. You're going to do okay, the internist will take care of you. But he doesn't go to an internist and he doesn't go to a nephrologist. We should see our own patients in follow-up. These patients have CKD when they're finished with their AKI. And you can see that very few of the patients are seen by a nephrologist. Only 50%. Too many patients. What kind of physician sees the patient as an outpatient? The nephrologist? It's terrible. Almost like a GP. The internist and the cardiologists are seeing these patients, and they are not concerned about the creatinine. They want to treat the hypercholesterolemia. So what should we do? I think we have to see our patients. I think we have to have good hypertension control, treat them like CKD patients, follow them closely, interruption of the renin-angiotensin-aldosterone system, low-protein diet perhaps. If we had good interventions against TGF-beta, that would be good. I think angiotensin interruption is a very good method to downregulate TGF-beta. We could have trials of VEGF promotion, P53 inhibition, and there is already a company working with Dr. Molatoris on inhibiting the cell cycle. And I showed you a slide before. We have lots of opportunities. We need people to write grants and do studies and be creative and see the patients after AKI, after dialysis. And I just put for your consideration a possible trial design. You could use any drug in this design. A 2x2 matrix, right? We have to do the studies, we have to see the patients. So, close to the end, what mediates the long-term outcomes of AKI? The residual renal function? We don't know. We don't know what the eGFR is of the patients when they're discharged. Nobody looks. The level of injury, peak creatinine, probably. Lack of follow-up by nephrologists, definitely. Socioeconomic issues, I believe this very strongly. I believe that AKI is, like CKD, a disease of poor people. They can't see the doctor easily. They don't come to the doctor's office 10 days after they're in the hospital. I have no money. Genetic susceptibility, I think it's very interesting. And that may be related to some patients having an overzealous fibrotic response versus some patients having a small response. And I think we have a major question, and we will be investigating this, and this is an area of big investigation to look at biomarkers that will predict outcomes. Now we don't have biomarkers that predict long-term outcomes. We have biomarkers that predict whether the patient has AKI or not. I can make this diagnosis without a biomarker. So, en conclusión, gracias por su atención y ¿hay unas preguntas?